Welcome to the ANEW Insight Podcast, empowering and inspiring your journey to optimal health. Hosted by Dr. Supatra Tovar, clinical psychologist, registered dietitian, fitness expert, and author of Deprogram Diet Culture. Rethink your relationship with food, heal your mind, and live a diet-free life. I follow my guests' journey to optimal health, providing you with the keys to unlock your own wellness path. Tune in and evolve with us. Hello and welcome. I am honored to have men's health specialist, Dr. Kian Asanad, with us today. Dr. Kian, welcome.
Thank you. Thanks for having me today.
I'm excited to talk to Dr. Kian about all things men's sexual health today. We're going to get into that along with some cutting edge treatments that he is working on, which I think a lot of men will be very fascinated to hear about. And I think that their partners will as well. Before we get into that, though, I'm going to read a little bit about Dr. Kian and then we'll jump into our questions. Dr. Kian Asanad is a fellowship-trained urologist and men's health specialist at Keck Medicine of USC, and he serves as director of the USC Fertility and Men's Sexual Health Center in Beverly Hills. He earned his medical degree from UCLA with Alpha Omega Alpha honors and completed his urology residency at Keck Medicine LA General Medical Center. He went on to complete his advanced training in male infertility, microsurgery, and sexual medicine at Northwestern University, one of the nation's top programs for andrology. Dr. Asanad specializes in treating low testosterone, ejaculatory dysfunction, erectile dysfunction, Peyronie's disease, and all forms of male infertility, including post-vasectomy fertility restoration, genetic or congenital conditions, and sperm production issues. He integrates cutting-edge diagnostics, including AI-driven tools, I'm excited to hear about this, and microsurgical techniques to deliver individualized, evidence-based care that supports both sexual health and reproductive goals. Okay, you've done just a little in your career. I mean, come on, catch up with the rest of society, Dr. Kian. You're kind of an amazing guy. I am really excited to pick your brain today.
Thank you for the kind introduction. It's really nice. It's a pleasure to be here with you today. I'm happy to go over and chat things men's health today.
Yes, definitely. I always start off with some inspiration. And so I want to know what inspired you to specialize in male infertility and sexual health, and what continues to motivate you in this area of urology.
Yeah, I had no idea I wanted to be a urologist growing up, and when I decided to be a urologist, I had little to no interest or didn't know anything about the fertility and men's health space. Was interested in oncology and interested in all things kind of just urology and cancer. And I had an amazing mentor during my training, Dr. Mary Semplasky, and I did some really cool research projects with her. And she really opened my eyes to the world of microsurgery, taking care of young men, who want to build a family. And something I've always been really passionate about that drew me to urology in general was taking care of men with very sensitive issues and focusing on surgery that really emphasizes quality of life. And I'm really able to accomplish that with whether, a couple wants to achieve another pregnancy after a vasectomy 10 years ago, or prostate cancer treatment resulting in a man being impotent and trouble getting an erection and being intimate with his wife, and focusing on surgery or injections or ways to help optimize their quality of life. And the men's health world really helps me accomplish those goals.
I think that that's so wonderful. I like how that you couch it. It's trying to bring back the quality of life to men. And so many men experience difficulties with erectile dysfunction or with fertility issues, especially from the age of like 40 up. What can you tell us? And I think this will help many men. What are the most common causes of male infertility that you see in your practice? And that includes erectile dysfunction in my book. And how do you typically approach diagnosis?
Yeah. So when I see a man in the office with or without their partner looking to evaluate their fertility, nowadays seeing guys who have not even tried to achieve a pregnancy, just want to know where things stand. And that's become very common. And so the evaluation is pretty straightforward for men. Just like in women, it includes hormones. Hormones are important for men. We check a testosterone, other hormones important for sperm production, known as FSH, LH. We check a prolactin level, estradiol level. Want to make sure that the hormones are optimized. Up to 10 to 15% of men who present for a fertility evaluation are found to have a hormonal imbalance, meaning low testosterone levels. And testosterone is important for overall vitality in men and sexual health, but also plays a big role in sperm production and sperm quality. So that's something that we check. It needs to be a morning blood test, right? Because that's when testosterone levels peak and are accurate. I send men for two semen analysis. Why two? There could be a lot of variability from sample to sample. Kind of want to see where numbers stand. So have them abstain from ejaculation for 2 to 3 days, semen sample in the lab, and we get those results. And finally, the third part is a physical exam. The physical exam is critical in the fertility world. Want to examine the size and the consistency of the testicles. We're feeling if there is a vas deferens on both sides, which is the tube that carries sperm. Some men have a congenital absence of the vas deferens, either on both sides or on one side, making them completely infertile from an obstruction standpoint. Those men need a sperm extraction procedure. I'm also feeling for something called a varicocele, which is one of the most common cause of male infertility. About 40% of men who present for a fertility evaluation will have a varicocele. Varicoceles are dilated veins around the testicle and the spermatic cord. And what they do is they can heat up the testicle. And the excessive heat around the testicle causes problems with sperm production, testosterone production, and over the time, the testicle can actually shrink, it can atrophy. So, all these kind of play a key role. Once we get that basic evaluation, I'll see the patients pretty quickly in the office. 3 weeks later, review all their results and discuss kind of next steps from there.
Wow, that is a very thorough diagnostic screening for sure. I am curious what might cause some of these issues like low testosterone. I mean, we can talk about the congenital issues in a moment, but what are the lifestyle factors that contribute to low testosterone and maybe even eventual infertility issues?
Yeah, most of the time it has to do with other medical problems, obesity, metabolic syndrome, diabetes, high blood pressure. All of those play a role in testosterone production. So, for example, if you're overweight or obese, the excessive heat around the testicles from adipose tissue on the thighs can heat up the testicle. Testosterone is also converted to estrogen in adipose tissue in the body. So if you have a high ratio of adiposity, the testosterone gets converted to estrogen. So estrogen goes up, the testosterone goes down, and men have hypogonadism.
Mhm.
Some men are actually incredibly healthy. They exercise, they're fit, they're not obese. And for some reason, the testicle just doesn't respond as much and make as much testosterone as others. So some men can have lower testosterone. But, I shed light on the fact that from a fertility standpoint, I just want it to be over 300. Not,
Mhm.
anything over 300 is normal. Most men are between 3 and 400. And it really needs to be confirmed on a second test between 8 to 10 in the morning to make that diagnosis. But things that can result in low testosterone that we talked about, obesity, these lifestyle issues. There's some data as you get older, your testosterone dips down a little bit. Some studies report 1% a year, but there's some newer studies that show even as you get older, if you maintain a healthy lifestyle, testosterone levels can remain normal. So I don't put a lot of stock in the as you get older. I'm 40 years old, my testosterone should be low now. Not usually the case.
Yes. So when we look at lifestyle factors, I really like to look at areas like the blue zones. And have you done any deep dives into the different types of lifestyle factors that help men keep their testosterone levels high, keep weight from forming in midlife, things like that? Have you looked into that at all and advise your patients accordingly?
Yeah, so there's been some really remarkable studies from Mo Kara, former president of the Sexual Medicine Society, published in the Journal of Sexual Medicine about a year or so ago, who looked at the impact of regular physical activity, exercise, whether it was at least 3 times a week for at least 30 minutes a day, on the impact of sexual function, both in terms of erections and testosterone, and noted significant improvement in both. So I tell men, it's not like you need to go to the gym for an hour a day every day, right? Even moderate activity, especially weight training in the large muscle groups, chest, quads, thighs play a big role in improving natural testosterone production.
Absolutely. And I've read a lot of studies. I'm on the nutrition side, so I'm all about all things nutrition and I've really like delved into these blue zones. And there's a lot of research out there that shows that if people adopt more of a plant forward diet, doesn't have to be completely plant based, but majority plant forward diet, people in those blue zones who have had those diets for
Mhm.
their lifetime tend to have higher levels of testosterone,
Wow.
tend to experience things like menopause in a much different way than we do in our Western cultures. So I always encourage people to try to make their diet as plant forward as possible,
Yeah.
incorporating a lot of plant proteins as well, because there's
Mhm.
some evidence that animal protein itself can contribute to some hormonal
Yeah.
fluctuations as well. Have you heard anything along those lines?
Usually in training, we mostly recommended a Mediterranean diet. It's actually a lot of patients ask about, is there anything I should be eating, not be eating? We recommended things like fish for protein, fruits and vegetables. Something on the Mediterranean side was a heart healthy diet. We say what's good for the heart is good for the penis. You'll hear other urologists say that. Same from a testosterone standpoint. Really, that's been my experience.
Absolutely, and I've heard too from doctors that, just like you said, actual problems with erectile dysfunction may be early signs of cardiovascular issues. Can you
Absolutely.
explain why that would be the
Yeah.
case?
Yes. So the arteries of the penis are even smaller than the coronary artery vessels. So they can be prone to signs of erectile dysfunction with hardening and plaque buildup even before signs of heart problems. So that's why we can kind of really see that. Cavernosal arteries compared to coronary arteries are different diameters. So they're very sensitive to a lot of those effects. So sometimes we see guys in the office, 50-year-old male, haven't seen a doctor since they were 18, right? And that happens, right? And they come in because it's a sexual health issue. I'm the first guy they've seen in 20 plus years, right? And so do an examination, we get a history, we do some blood work, right? And so if they haven't had a primary care doctor, I'll order things like a screening lipid panel, a hemoglobin A1C to rule out underlying diabetes, check a testosterone level to see if their hormones are optimized, and then go from there. So that's the underlying reason for why men with erectile dysfunction are at an increased risk for cardiovascular disease, especially if the ED is vascular in nature, like organic and not anxiety related or something like that.
Absolutely. I think it's so important, you guys out there. You got to look at your heart health if you want to address your sexual health. And certainly, I think the Western diet does not promote heart health or sexual health.
Neither,
And
neither.
so, rethinking our plate, I think, can be one of the most important ways to age with strength and grace. So maybe a few more
Absolutely.
plants, you guys, and maybe not the carnivore diet. Please don't do the carnivore diet. Please, please, please.
Yeah.
Let's talk about vasectomies.
Yes.
So, men who have vasectomies can have it reversed. What are the options for restoring fertility? How successful are they?
Sure. Yeah. So a man has had a vasectomy, and for one reason or another, they like to achieve another pregnancy. Most commonly has to do with a separation and a new partner. And really, what I find in my practice, achieving a pregnancy together really helps cement that relationship. So yeah, I totally get it. They want to have a child together, and that makes sense for a lot of couples. So there's some other less common reasons that can include if you had a vasectomy at a really young age is kind of a risk factor. Very rarely could be a death of a child and wanting another pregnancy. but up to 5 to 6% of men will undergo a reversal process. So, options for fertility after vasectomy, we can reverse the vasectomy, which is a microsurgical procedure, something that I perform in the operating room. It takes a couple hours. We freshen up the ends of the vas deferens, examine the fluid that comes out of the vas deferens, and look for sperm. And if I see sperm there, it tells me the whole pathway to the vas deferens is nice and open. I use a microscope to reattach the vas deferens to the other side of the vas deferens. And it's really remarkable. I mean, every time I do it, I'm still mind blown about the end result because the sutures, the stitches we use are finer than human hair. That's how tiny they are. And it's a two-layer closure. I mean, we're closing the inner layer of the vas deferens, the outer layer of the vas deferens. It's definitely a process. The good news is the success rates are north of 95%. If I see sperm in the operating room, the chance that I get sperm back in the ejaculate is very high, even if your vasectomy was 20 years ago. Sperm in the operating room, reconnection, over 95% success rate. Of course, getting sperm in the ejaculate doesn't translate into a take-home baby, right? Female factors need to come into play. So, if a female partner is 42 and the man is 50, the vasectomy was 30 years ago, we might think about an alternative approach, which could be considered in any situation, and that's extracting sperm, right? The testicle is still making sperm. It's just there's a roadblock. It's not going anywhere. It gets reabsorbed by the body. So it could take a pinch of tissue from the testicle directly or the epididymis, which is the gland behind the testicle, and use that for in vitro fertilization or IVF, where they inject a single sperm into an egg to create an embryo and ultimately implant that in the uterus. The final approach, which is sometimes what I do in practice, is a combination of both. Maybe we're kind of not 100% confident that a natural pregnancy is achievable based on patient's age, their history. So we'll do a reversal procedure. And at the same time, we can freeze sperm and take a pinch of tissue from the testicle. And that way, if the reversal is not successful or didn't result in a natural pregnancy, patient already has frozen sperm ready to go. And if they want to pivot and do IVF with that, that could spare them a second procedure. So those are really the kind of the three options available.
What do most people choose?
It's like 50-50, I would say. It really just kind of depends on the couple's timeline and their kind of reproductive goals. I think most patients who I see, obviously there's a selection bias. If they're coming to see me, they want a reversal so they can have a natural pregnancy. But there is a misconception. I mean, like there's this thought out there that, oh, if your vasectomy is more than 10 years ago, chances success rate's really low. It's not the case. It really has to do with finding sperm in the operating room. I had a patient who had a vasectomy 30 years ago, found sperm in the operating room, vas to vas connection, had a pregnancy 3 months later. I mean, it's really remarkable what could be achieved. So, just kind of counsel the patients and just tailor it to their goals.
I am so curious how you do that suturing.
Yeah.
If can you just give us a picture? I can't even imagine trying to sew something thinner
Yeah.
with a thread thinner than a human hair.
Yeah, it's really tiny needle. It's if you even lose the needle, we don't even take an X-ray. I mean, normally in surgery, if there's a needle missing, everybody stops. We have to take an X-ray. Where's the needle? You can't even see the needle on an X-ray. So, I mean, that's how tiny it is. And so it's called a 10-0 nylon suture, right? Most sutures in surgery are 3-0, 4-0, maybe 5, 6-0 at most. Ophthalmologists are kind of using, 9-0, 8-0 nylon sutures. So it's really it's one of my favorite surgeries. It's one of the most gratifying surgeries. I love the kind of the delicate nature of it. And nowadays I get to train other trainees with it in our department. So, having residents rotate with me and learning microsurgery, it's really gratifying.
Very, very cool. Well, I'm so glad you're able to restore people's fertility. Now, let's touch on some congenital and genetic issues that
Mhm,
can cause male infertility.
mhm.
How can men find out if that's affecting them?
So, a couple things. So, when we check the testosterone, we also check two hormones from the brain called LH and FSH. LH stands for luteinizing hormone. It's a hormone from the brain that stimulates the testicle to make testosterone. The other hormone that comes from the brain or the pituitary gland is FSH, which is follicle stimulating hormone, which stimulates the testicle to make sperm. So two hormones from the brain, they interact with the testicle. One makes testosterone, one makes sperm. So when we do these tests, the reason I check them is to see if there is why is the testosterone low if it's low? Is it the testicle is not making a lot of testosterone? Or is the brain not making the hormones needed to tell the testicle to make sperm and testosterone? So with that, so if the LH and FSH come back undetectable, they're zero. That tells me the brain's not making these hormones. It's either there's a tumor in the brain compressing the pituitary gland, or there is a congenital absence of the hormone production from the pituitary. So what we do is we order an MRI of the brain to make sure there's no tumor there. Sometimes that comes up. That is pretty rare. Most of the time, it is a congenital absence of production of those two hormones. The good news is it is incredibly treatable, super treatable. We basically I just replace those hormones. I give men the LH, which is a medication called HCG. And then about 6 months later, I give them FSH through a medication. They're both injections. And they could stimulate normal testosterone production and normal sperm production. Over 90% success in getting sperm back in the ejaculate to achieve a natural pregnancy. So that's one congenital reason men may be infertile.
And if they have the tumor, which I think would be very frightening, what
Yeah.
are the options there?
You usually refer them to neurosurgery. Sometimes it's a benign tumor called a prolactinoma. It's just a benign pituitary tumor that secretes prolactin, which is one of the hormones that comes from the brain. And when that happens, the prolactin levels go really high and the rest of the hormones come down. And it's totally curable. Once it's treated, everything can kind of normalize.
Wow, that is amazing. And how many men do you think present with these congenital or genetic issues?
It's pretty uncommon. It's about 5% or less. That's kind of one way congenitally can cause infertility. Other congenital causes of infertility can include, we talked about absence of the vas deferens, right? The
Mhm.
tube that carries sperm. So men with cystic fibrosis, CF, cystic patients are infertile. They all lack the vas deferens on both sides.
Mhm.
But the good news is, again, totally treatable. Those men are making sperm. I kind of think of it like they had a vasectomy, basically. There is no tube to carry the sperm. They're making tons of sperm. It's in the testicle. Those men do need IVF to achieve a pregnancy. We can't reconstruct the vas deferens. We don't really have that capability. So we'll just take a pinch of tissue from the testicle. They'll use it to perform IVF and achieve a pregnancy. I mean, and the results are excellent. So that's why the physical exam plays a big role. Other congenital causes can include issues with chromosome numbers and abnormalities. So, Klinefelter syndrome is relatively common, right? Men having an extra X chromosome. So, men have 46 chromosome and X and Y chromosome. They could have a second X chromosome. So, there's 47 chromosomes, XXY. The majority of patients, over 90% of patients with Klinefelter syndrome, are infertile. They don't have any sperm in the ejaculate. Many of these men also have issues with low testosterone. So the testicles atrophy. They become kind of very tiny, kind of like peanut sized testicles, if you will. And they become fibrose and non functional with time. The good news is also surgical sperm extraction is successful in men with Klinefelter syndrome. It is remarkable. We can open the testicle and surgically look for sperm, about 50% chance of finding sperm, and that could be used for IVF to achieve a pregnancy. I've had patients in the office present with infertility, totally normal looking guy. We do an exam, I'm like, his testicles are really atrophic, comes back with zero sperm, send him for genetic testing, and he has Klinefelter syndrome. I mean, it's just like, most of the time that's not the case. It's usually caught earlier in life, but sometimes, couples are young, they're 25. A lot of the findings of Klinefelter, like we think of tall stature and breast enlargement and small testicles, you don't really see them all the time. It's a very broad spectrum. So sometimes we diagnose it. I've diagnosed cystic fibrosis just based on infertility. absence of the vas deferens and they're a carrier for cystic fibrosis or have a mild form of it. The fertility tells you a lot about the overall health of the patient, which is really fascinating to me.
Totally, absolutely. And I can imagine that these congenital or genetic issues are pretty rare.
The majority of them are pretty uncommon. Klinefelter syndrome is a little bit more common. It's about 1 in 500 men have Klinefelter syndrome. So it's not that uncommon, right? But the congenital absence of the hormones from the brain to the testicle, cystic fibrosis is also relatively common. These are kind of the most common congenital abnormalities. And finally, the last one is something known as a Y chromosome microdeletion. I mean, had a patient today. So men have an X chromosome and a Y chromosome, right? We've identified on the Y chromosome, on the long arm of the Y chromosome, there's 3 different areas that if they're abnormal or mutated, it results in 0 sperm or very low sperm counts. These are known as AZF or azospermia factor A, B, and C. We're getting a lot into the nitty-gritty here, but it's good. I send men for these tests most commonly if they have no sperm. So 10 to 15% of men who come into the office who have no sperm will have an AZF microdeletion. It's very important to know why. If the A or B is abnormal, there's 0% chance of finding sperm. We don't do any sperm extraction for those patients. Unfortunately, they need to consider donor sperm or adoption. If there's a C microdeletion, those patients can have sperm at the time of a sperm extraction. But most importantly, men with a Y chromosome microdeletion, if they're able to achieve a pregnancy, all of their male offspring will also have this deletion, meaning they will also be infertile.
Wow.
Very, very important to know. So if the couple's undergoing IVF and they have an AZF microdeletion and the sperm counts are low, I counsel them like, obviously gender and sex selection has the kind of own ethical issues. It's, could be done in California. When I was in Illinois, it's not a thing. Any male offspring will carry that mutation, will also suffer from infertility.
So you can choose the sex of your child in California?
Depending on the center, yeah, it's usually, it's not marketed as that, I would say, but you develop embryos. If there's male and female embryos, you could pick what embryo you want to choose. Nobody's choosing for you. But
Wow.
if the rules behind let's do IVF because we want to have a boy, still probably okay. But I think it just depends on the practice patterns of the IVF physician.
Absolutely. Oh, well, I have a million more questions for you, and we are out of time for this half of the podcast. And I really want to get into AI and all of the kind of cutting edge things that you are doing. So you're going to have to hang out with me and come back
Yes.
with me for the second half of the podcast. And everyone, oh my goodness, come back to hear more because we are talking with somebody who is at the cutting edge of infertility, restoration, men's sexual health, erectile dysfunction. So come on back and tune in for men's health specialist, Dr. Kian Asanad. Thank you, Dr. Kian.
Thank you so much. It's been a pleasure.
Thanks for tuning into the ANEW Insight Podcast. Please remember, the contents shared on this podcast is for entertainment purposes only and does not constitute medical advice. You can find us anywhere podcasts are streaming, on YouTube at my.anew.insight and at anew-insight.com under the ANEW Insight Podcast tab. And follow us on our socials at my.anew.insight on Facebook, Instagram, TikTok, and Threads for more updates. Tune in next time and evolve with us.